We will start this series, the head and neck series, with this lecture. Of course, we will start with the neck and we'll go upwards. The neck is a transition zone between the upper limbs, the thorax, and the neck region. So, what do you expect to find in the neck? It's cylindrical in shape, it's a channel, contains a midline structure pillar, which is the cervical vertebrae, cervical column, and anterior to it there is the pharynx and the beginning of the esophagus, and anterior of all is the airway, which is the larynx and the beginning of the trachea. On the sides you'll find many muscles, either muscles connecting to the vertebral column to act upon, or connected to the head, like in case of this muscle. This is the sternocleidomastoid muscle, which acts on the head. What else will you find? Of course, blood vessels, major blood vessels going to the head and neck and coming back from the head and neck, and nerves, either spinal nerves coming out of the spinal cord or cranial nerves coming out of the skull. So this is the neck, as simple as that. Look at the side. This muscle, the sternocleidomastoid, differentiates the whole region into anterior triangle, which is the base upward, has the base upwards, and the posterior triangle, which is the base, has the base downwards. They are opposite each other. It's a landmark. We will study it later. But now we will start with the osteology of the cervical vertebrae. We have 7 cervical vertebrae. Note that we have 8 nerves, cervical nerves. So we have 7 vertebrae. We have a C7 vertebra, but we do not have a C8 vertebra. We have a C8 nerve. You can classify the vertebrae into typical vertebrae and atypical. Typical means they are most of the vertebrae and they share common criteria. The criteria are, for example, the body, small oval body. It has a transverse process with prominent foramen transversarium with anterior and posterior tubercles. It has a pedicle that connects the body to the back structures, which are the superior and inferior articular processes, the laminae that meet in the middle to form a bifid small spine. Bifid means split. These criteria mark the cervical vertebrae, and note that the foramen transversarium, you won't be able to find it in other regions. It differentiates the cervical vertebrae from other vertebrae. Now, a couple of points about the articular processes. The anterior articular process of C6 is called the carotid triangle. Why? Because we can rub the common carotid artery against it to decrease the sympathetic outflow. يعني لما يعلى عليك الضغط شوية وعايز تهدي الضغط عن طريق ريفلكس اكشن، فرب او دلك الحته اللي قدام الانتيريور بوردر اوف the sternocleidomastoid. انت كده بتدلك الكومن carotid artery وبتضغطه against mainly the C6 anterior tubercle. That's why it's called the carotid carotid tubercle. Also because this tubercle of C6, it separates the vertebral artery from the common carotid artery lower down. Now, another point regarding these tubercles, anterior tubercles, they are of the same origin as ribs. So pay attention to this, because as an anomaly, where someone might get an enlarged anterior tubercle to form a semi-rib, something like a rib, but in most cases it will be formed of fibrous tissue. It doesn't turn into bone, but rarely it turns. But what happens in either case, there will be compression of the adjacent structures, like the vessels, major vessels going and coming from the upper limb, and the nerves going to the upper limb. So the patient will feel numbness or tingling sensation, or even pain, shooting pain in the upper limb. Um, and reduce vascularity, reduce blood flow, so that you'll get ischemic change in colors of the limb, and the tingling sensation because of the decreased blood flow. So this is an articulated image of articulated cervical vertebrae. You can count 7 vertebrae: 1, 2, 3, 4, 5, 6, 7. I want you to notice that the upper vertebra, which is the atlas, actually has no body. The body is being replaced by the odontoid process of the axis, which is the C2. That's why these two vertebrae, because they are different in criteria than the rest of vertebrae, that's why they are classified as atypical, the atlas and the axis. And look here at the spine of this vertebrae. This is C7. The spine is prominent, long, and non-bifid. That's why it's called the cervical prominence, because you can feel this bony prominence at the base of the neck, at the back of the neck, and from there you can start to count the spines of the vertebrae below it: T1, T2, T3, and so on. So this you should come out with this articulated view. Also, I want to draw your attention to something very important. Look at this foramen, and this and this and this. These are not the transverse foramina or foramina transversaria. These are the intervertebral foramina. Each intervertebral foramen is formed by 2 notches of adjacent ribs or adjacent vertebrae, and the articular processes and pedicles. So this foramen is shared by 2 vertebrae. So if you notice, if this distance decreased due to compression, for example, of the vertebrae, the structures coming out of this foramen will be affected. What comes out of here? Spinal nerves. Nerves that will supply the neck and the upper limb, and vessels going to and coming out of the adjacent spinal cord. So we get this in a case called spondylosis. We will come to it when we study the joints of cervical vertebrae. But for now, look how many sites the vertebrae articulate actually. Between the bodies, we have intervertebral joint. Between the articular processes, we have zygapophyseal joint. And don't forget the special joints, the atlantoaxial and, of course, the atlanto-occipital with the skull. Now, this is a picture of atypical vertebra. This is C1, which is the atlas. What's atypical about it? Well, tubercles are not that prominent. It doesn't have a body. It has an anterior arch instead, and 2 lateral masses, with the superior and inferior articular processes on the sides of that mass, superiorly and inferiorly. It has a posterior arch longer than the anterior arch, and the posterior arch, there are no spine. There is a tubercle called the posterior tubercle. So it has an anterior tubercle, posterior tubercle, but other than the tubercles you used to see on the transverse processes. That's one thing. And it doesn't have a spine, it doesn't have a body. Instead, it's thrown into 2 lateral masses. This is how to differentiate between anterior and posterior. What about superior and inferior? Well, remember this, that the skull is heavy, so it indents the superior articular process, grooves it more than the inferior one. And that's how you differentiate the upper surface, superior surface, from the inferior surface. Now, this is the axis. Look at that. It's huge. It's bulky. It has the bifid spine. it has the foramen transversarium in the transverse process, but instead it has a projection from the body. It's called the dens or odontoid process. Remember that the odontoid process is the remnant of the notochord that forms the bodies of vertebrae. Remember that. It goes upwards to articulate with the inside of the anterior arch of the atlas to form the atlantoaxial joint. Okay? So the atypical vertebrae, we have C1, C2, and C7. For the joints, now I mentioned before that sites of articulation are the bodies. It's called the intervertebral joint, intervertebral joint. It has an intervertebral disc in it, disc of cartilage, fibrocartilage. This disc is composed of central part called the nucleus pulposus and annular peripheral part, which is the annulus fibrosus. It's layers of cartilage enforced with fibrous tissue fibers to make it tough cartilage. So this joint in the middle between the bodies, please guys, I want you to pay attention to the detailed info we say about anything, because these detailed info are actually the MCQ choices that you encounter, the A, B, C, D, E. These are the options that you encounter for each question. So don't skip that. I will try my best to make it as concise as possible, but also to not to miss answering any question about the vertebral column. So the intervertebral joint is a symphysis joint, cartilaginous symphysis joint, and the main component, of course, is the intervertebral disc. This disc with age or a degenerative disease might get thinner and thinner, so leading to compression of vertebrae. We will talk about that soon. Now, what other site of articulation? See that between the articular processes? These are called these zygapophyseal joints. They are plain synovial, not cartilaginous. Means that they allow for movement. Plain synovial joints, gliding movement between the vertebrae. So you have the intervertebral, between the bodies, and actually this is called intervertebral too, but to differentiate it than the middle one, it's called the zygapophyseal joints between the articular processes. Okay, so actually each vertebra articulates with a vertebra above or below in three sites, in two articular processes and the body. Great. Look at this. This is the atlantoaxial joint between the odontoid process and the back of the anterior arch of the atlas, and this is the site. And of course, this joint is classified as synovial pivot. Pivot means it has rotatory movement in it. So we will come to it in detail soon, but think about the movements of the head for a while. Now here, the joint formed is the atlanto-occipital joint, which is synovial, condyloid, and it was previously classified as ellipsoid. It has movements in different directions. So these are the joints between the cervical vertebrae. Please don't forget, we talked about spondylosis, which is degeneration of the intervening disc here. We have a case called disc prolapse اللي هما لو جت تحت في الظهر بتبقى اسمها disc. And the disc gets torn, the annular fiber gets torn, and the nucleus pulposus bulges outside, usually backwards and lateral, to compress the nerves coming out before they come out of the vertebral canal. This is the typical manifestation of disc prolapse. What else? Say a case of spondylosis, we know that it's narrowing of the spaces here. You can get compression of the coming out nerves, so you have symptoms in the limbs varying between tingling sensation and pain shooting in the limb according to the number of nerve or the nerve number that is compressed. What else? We have a very important structure here that runs in the foramina transversalia going upward. Another one comes and goes downwards in the foramina transversalia in series. These are the vertebral system, the vertebral artery and the vertebral vein. Now, the vertebral artery, you should know that it supplies the base of the brain and the occipital lobe of the brain. It's a major artery. So when the distance gets shortened or the discs are compressed, what will happen to this artery? For example, if we, with a sudden movement of the neck to the side, rotation of the head, for example, or sudden hyperflexion of the hyperextension of the neck backwards, what will happen to this artery? It will be compressed. And since it's already compressed because of the shortened distances between vertebrae, any further compression will obliterate or compromise the blood flow. That's why the test is when you ask a patient to look at the side and faints. This is a sign of what's so-called the transient ischemic attack. Transient ischemic attack, or TIA, results from compression of the cervical vertebrae, and so the vertebral system in the foramina transversalia will be compressed as well. Pay attention to this, please. Look at this. We have the upper two vertebrae from the front and from the back. There's a ligament on all the vertebrae, actually cervical, thoracic, lumbar, and sacral. It's called the anterior longitudinal ligament. It's on the anterior part of the body of vertebrae. It comes up here and expands to form a ligament between the atlas and axis, called the anterior atlanto-occipital membrane. You will be asked about this. What is it a continuation of? It's a continuation of the anterior longitudinal ligament. Now, this is a posterior view. See, this is the atlas, and this is the base of the skull. We have another membrane called the posterior atlanto-occipital membrane. Actually, this membrane differs than the anterior one. This membrane is rather elastic, rich in elastic fibers, because it's derived from a ligament called ligamentum flavum. Ligamentum flava, or flavum, flava means yellow. It's yellow because it's elastic, rich in elastic fibers. That's why the posterior atlanto-occipital membrane is elastic too. Now, please pay attention. The anterior atlanto-occipital is a continuation of the anterior longitudinal. The posterior atlanto-occipital is not continuation of the posterior longitudinal, it's continuation of the flavum, because the posterior longitudinal ligament actually is present at the back of vertebrae, body of vertebrae, not the back of the vertebra, back of bodies. So it's inside the vertebral canal. See that? This is the posterior longitudinal ligament. It expands upwards to form what's so-called the membrana tectoria, or tectorial membrane. Now, this is the back of the skull and back of the, this is the foramen magnum, and this is back of the atlas. If you peel that out, means you go anterior further deep, you'll find another ligament with a very prominent and tough transverse part called the transverse ligament of the atlas, and upward extension. That's why the whole thing called the cruciate ligament. You either call it cruciate ligament with counting the upward extension, or this part alone is called the transverse ligament of the atlas. It's very tough, and actually it's the one that holds the odontoid process of the axis against the posterior surface of the anterior arch of the atlas. Pay attention to this, please. See, when you remove this ligament further anterior or deep, last ligaments you will find an apical ligament and two alar ligaments to the odontoid process that connect the odontoid process to the margins of the foramen magnum. This is foramen magnum, and this is the hypoglossal canal in the occipital bone. Oriented now, this is a posterior view, and we are going deeper, means going anterior. We are inside the vertebral canal, and these are the backs of bodies of vertebrae. This is the superficial one, membrana tectoria, continuation of the posterior posterior longitudinal ligament. Then if you strip it off, you will find the cruciate ligament. When you strip them off, you will find the apical and alar ligaments to the dens, connecting it to the margins of foramen magnum. Now this joint is the atlanto-occipital joint. It's classified as synovial pivot. Pivot means you get rotatory movement in the joint. So this is one thing. Second, now we're talking about rotation here. So when you rotate the head, you're actually rotating the head and the atlas with it on the axis. So in rotation, the atlas and the head move as one mass on the odontoid process of the axis. This is the atlanto-axial joint. While nodding of the head, flexing the head, occurs only in the atlanto-occipital joint, which is the plain condyloid joint or ellipsoid joint. You got the difference? In rotation, you have the skull plus atlas moving, but in flexion and extension of the head, only the skull is moving on the atlas. The hyoid bone. I hope you got a good idea about the cervical vertebrae. What we said so far is very important, so please pay attention to it. In hyoid bone is U-shaped. The base of the U being the body of the hyoid, and the limbs of the U are the posterior cornea of the hyoid bone, or posterior horns of the hyoid bone. It has two lesser horns coming out of the body anteriorly, lesser cornea and greater cornea. The unique thing about the hyoid bone is that it has no direct articulation with any other bone, and high up in the middle of the neck, and plays a role like an anchor for the infrahyoid and suprahyoid muscles, which are connected to the bone, and backwards it's connected to the pharynx. Now the fascia. The fascia of the neck is divided into superficial layer and deep layer or deep collections of fascia. The superficial layer has a fibro-fatty tissue in it. It's continuous with all the superficial fascia of the body and contains some structures that you should know. It's biologic structures that appear under the skin, like or supply the skin, like cutaneous nerves, like veins. The prominent one is the external jugular vein. A muscle, which is considered one of the muscles of facial expression, which is the platysma muscle, And as you can see here, it descends from the base of the mandible till the clavicle, or inserts actually in the mandible and arises from the skin over the clavicle. It may vary, it varies with individuals. It may arise from the pectoral region or maybe very short and arises totally in the neck. So you have veins, external jugular vein, you have cutaneous nerves, you have a muscle of facial expression. This is regarding the superficial layer. The deep fascia or deep layer actually is subdivided into a superficial investing layer of the neck. This is very important fascia. It gives the contour of the neck. It holds the structures in the neck in place, holds them in place. It's like a tight sleeve over the neck. And deep collections of fascia thrown into like pretracheal fascia, prevertebral fascia, carotid fascia, and we will study them in time. Now, let's talk a little about the superficial layer. The superficial layer, which is superficial of the deep, I mean, the investing layer. Now you will be asked about the attachments. Though it looks very hard in books to learn all the attachments by heart, but actually it's use logic in this. Yep, you have a sleeve you want to connect it upwards at the margins of the skull to the skull and downwards to the bony prominences down there. Downwards, it connects to the clavicle, it connects to the acromion of the scapula. Upwards, it connects to the base of the skull and mandible. If you want to talk about that in detail, the fascia arises in the midpoint at the back of the occipital bone and then goes laterally on the superior nuchal line. It's attached to this flexure, skin bone flexure you see in bald people from the back. This is the site of the superior nuchal line. It comes to the mastoid process at the front, attaches to it. Now it wants to jump to the mandible, the inferior border of the mandible. How will it do that? There's a ligament and a gland. The gland is the parotid gland, of course it's not here. The ligament is the stylomandibular ligament. The fascia splits and forms the capsule of the parotid gland, reunites, and from the deeper aspect, it sticks to the stylomandibular ligament, and that's how it jumps the area between the mastoid and the mandible. Now it's attached to the lower border of the mandible till it meets the investing layer of the other side at the middle of the mandible. Now when you go down, it's attached to the hyoid bone, and that's why it gives the contour of the neck, not the skin or the superficial fascia. The skin or superficial fascia sags with age, while the investing layer doesn't. When you go further down, unites with the other investing layer in the midline. Above the manubrium sterni, it splits to form a supramanubrial or suprasternal space, attaches itself to the clavicle. Now we have two opinions here. Some consider the investing layer ends in the clavicle and that's it, and some considers it it splits to enclose the clavicle, becomes the periosteum of the clavicle, reunites after the clavicle, and forms what's so-called the clavipectoral fascia and continues down to the axilla. So it's according to the source you're reading from. What else? It's attached to the acromion, but it has a big obstacle here, the trapezius muscle. The fascia splits to enclose the trapezius, becomes the epimysium of the muscle. Also, it splits to enclose the sternocleidomastoid muscle. Down there in another image, see this, the omohyoid muscle, the muscle that comes from the scapula downwards and goes up to the hyoid bone. The investing layer sends a slip that fixes the lower belly of the omohyoid muscle to the clavicle. That's why it has two heads and the central tendon. The deep fascia of the neck, I told you it's thrown into many different parts. Prevertebral fascia, pretracheal fascia, and carotid sheath. The prevertebral fascia, it's simply the fascia that covers the prevertebral muscles. Now, I want to tell you something about the prevertebral muscles. It's known as prevertebral, they are known as prevertebral muscles, but actually the accurate classification that we have prevertebral muscles that are in front of the vertebrae, just at the front, like the longus colli, longus capitis muscles, the longitudinal muscles on the vertebral column. While the muscles at the sides, the ones you see here in the posterior triangle, are called the scaleni, for example. They are called prevertebral muscles, but they are actually paravertebral muscles at the sides of the vertebrae. So you have pre in front and para at the sides. But in general, all of them are called prevertebral muscles. Pay attention to this fact, please. And trust me, it differs if you're answering a question in the American system rather than the British system, for example. The British system are more extra precise. The prevertebral fascia actually attaches to the vertebra at the anterior surface of the bodies, goes laterally to enclose all the paravertebral muscles, and ends back by meeting its fellow prevertebral fascia in the superior, in the what they're called the nuchal ligament. It's opposite the backs of the spines of the cervical vertebrae, ligamentum nuchae. The prevertebral muscles, the prevertebral fascia, if you look down in the posterior triangle, you'll find that the muscles are leaving with some vessels and nerves. Now, these vessels and nerves must either stay hidden by the prevertebral fascia, but this is not possible because they are going on their way to the upper limb, so they must go further down. Or they pierce the prevertebral fascia. This is not the case. What happens is the vessels and nerves take a sleeve of the prevertebral fascia around them. This sleeve continues in the axilla as the axillary sheath. Now remember, when we talked about the investing layer, we said it ends in the axilla, ends by becoming what's so-called the suspensory ligament of the axilla. But the prevertebral fascia, in this case, in this specimen, the part that envelopes the vessels and nerves going to or coming from the upper limb, are called this envelope is called the axillary sheath, and that's it for the extension of the prevertebral fascia laterally. At the front, now something happens and it differs in sources, but I trust Gray's Anatomy, and this is my main source actually of information, Gray's Anatomy. The prevertebral fascia at the front, while descending, it splits into two layers. Now I want you to imagine that. You are at the front of the cervical vertebrae, right on the bodies, and the fascia descending, it splits into two layers. An anterior layer that will curve anterior and unites with a fascia there called the buccopharyngeal fascia, because the pharynx will be in front of you. If you are standing on the vertebrae, the anterior surface of vertebrae, cervical vertebrae, you will find the pharynx in front of you when you look forward. Now, you are covered by a posterior layer of prevertebral fascia, and the anterior layer will go and blend with the back of the structure you see in front, which is the back of pharynx and its buccopharyngeal fascia. Now, what happens to the posterior layer? It goes down on vertebrae and blends with the anterior longitudinal ligament and muscle fascia at the level approximately at T4 level. So you will end up with a space between the posterior layer and the vertebral, the prevertebral muscles, a space between the two layers of the prevertebral fascia, and the space between the anterior layer and the buccopharyngeal fascia. Now, we will come to these spaces now, but I just now want you to imagine what's happening there by the prevertebral fascia. Okay? Okay. The other fascia is the pretracheal fascia, means it's in front of the trachea and larynx. Well, it's not, this is not the case. It's called pretracheal fascia, but actually it envelopes the trachea and the esophagus till their posterior surfaces. So actually it envelopes the whole thing, the pretracheal fascia. Envelopes the food passage and the airway together, with the thyroid gland on the trachea enclosed in this tissue envelope as well. Imagine that. You have the pharynx and esophagus posterior. You have then anterior to it the larynx and trachea. On top of trachea you have the thyroid gland, and all these structures are enveloped in what's so called the pretracheal fascia. Now, the posterior part of the pretracheal fascia is called the buccopharyngeal fascia. This is the buccopharyngeal fascia we mentioned earlier, that receives the anterior layer of the prevertebral fascia from the back. Got that? And there's a space between the anterior layer and the pharynx. Now it's called the buccopharyngeal space. One can get an abscess here. It's called the retropharyngeal abscess in this space. Now the importance of these spaces will come in the after one or two slides. Now this is the pretracheal fascia, and what does it do? Last of the fascia, collection of fascia in the form of envelope 2, called the carotid sheath. Now the carotid sheath is a condensation of fascia. Below, it's around the internal jugular vein, the common carotid artery with the vagus nerve in between and posterior, together with an ansa cervicalis. It's a loop of nerves embedded in the anterior wall of the carotid sheath. When you go upward, now the common carotid divides into internal and external carotid arteries. Now the external, remember this fact, external becomes external. It stays external. It goes out of the carotid sheath. What remains is the internal carotid artery together with the internal jugular vein and the vagus nerve in between and posterior. When you go high up, you will find other structures like the lower four cranial nerves, 9, 10, 11, and 12, the glossopharyngeal, the vagus, the accessory, and the hypoglossal. But actually, the accessory, this is not, it's a misnomer. It's not a cranial nerve, it's a spinal nerve that has a very, very unique course. Well, we will discuss this later. This is about the carotid sheath. Please don't forget that encloses the major the structures it encloses: internal jugular vein, common carotid artery, internal carotid artery, the lower four cranial nerves. Embedded in its anterior wall is the ansa loop of nerves called the ansa cervicalis to supply the infrahyoid muscles, and that's it. Of course, any branch of any structure inside the sheath has to pierce the sheath. For example, glossopharyngeal nerve has to go anterior, it pierces the sheath. The vagus stays in the sheath, but a branch of it, two branches actually, come out and pierce the sheath, like the pharyngeal branch of vagus that is below the glossopharyngeal nerve, and the superior laryngeal nerve actually that goes to supply the larynx. It's a branch of vagus, so it has to pierce the carotid sheath. You got that? Good. This is about what's important about the carotid sheath. Now, for the spaces, I tried my best to bring a specimen or a picture that I can show you the spaces. Now, see the vertebral column. See the larynx in front with the vocal cords. This is one of the vocal cords. This is the left vocal cord showing, and the space between it and the right one is very prominent. This is at the upper border level of the upper border of C6. So the larynx behind it is C6, C5, C4. Part of C3 is showing, and C7, part of CA is T1 is showing. Now, in front of the vertebrae, you see the condensation, fibrous tissue. These are the ligaments, anterior longitudinal ligament, with a thin fascia. Of course, you can't differentiate in this actually very beautifully dissected specimen provided by Stanford University School of Medicine. I'm talking about these spaces. You see the spaces behind the esophagus, behind the pharynx, esophagus, the prevertebral space. You see the one directly behind the pharynx is called the retropharyngeal space between the it's covering fascia, the buccopharyngeal fascia, and the anterior layer of vertebral, and so on. The space that you see in the middle, which is very prominent behind the esophagus in front of the C6 vertebra and down, this space, which is between the two layers of the prevertebral fascia, you can go down with it to the diaphragm. Now, this is the problem of retropharyngeal abscesses. The if you are, if you know your stuff, what you're doing with the patient, you should and properly diagnose a retropharyngeal abscess by proper examination. Don't hesitate to end this actually surgical, because the pus behind the pharynx, if increased in amount, it may trickle down along this plane of infection down through the mediastinum, posterior mediastinum, until you reach the diaphragm. This is a disaster. The patient then is turned into an ICU patient and rarely recovers from a general mediastinitis. They call it mediastinitis. fulminant mediastinitis. It's a very dangerous case. So see, it comes by the way the retropharyngeal abscesses, very common with after puncture with fish thorns, fish spines. One spine sticks there, and of course it's not clean and contaminates the surrounding structure, and pus inflammatory reaction starts to take place with horizontal pus in the retropharyngeal abscess. Okay, pretracheal space is the one between the pretracheal fascia and the skin and fascia in front of it. This is called the pretracheal space. Of course, it reaches down to the superior mediastinum as well. So remember, the pretracheal space in front of the pretracheal fascia and the hypodermis of the skin, it goes to the superior mediastinum. The retropharyngeal space between the buccopharyngeal fascia and the anterior layer of vertebral, and the third space, it's the layers between the layers of the prevertebral fascia itself, from the skull down to the diaphragm. This is a specimen, shows you the origin and course of the external jugular vein. External jugular vein is a superficial vein. It's in the superficial fascia of the neck. It's formed by the union of the anterior division of retromandibular and the posterior division of retromandibular and the posterior auricular veins. The posterior auricular comes from behind the ear. They form the external jugular vein, runs down and crosses the sternomastoid from medial to lateral, and pierces the deep investing layer to drain inside the internal jugular vein. Sorry, the subclavian vein. I know there's something wrong. So it drains into or a tributary of the subclavian vein. Now I want to talk about this. I was concentrating on the pierced side. The vein pierced the deep, the investing layer of the skin, of the fascia, of the neck, investing layer. Now this is a tough fascia, and when a vein pierces it, it doesn't leave it loose. It sticks to its walls, and subhanallah, this is one of the mechanisms that the fascia aids the vein in according to the direction of blood flow. It keeps the vein open for continuous tension on the wall of the vein. And you studied in histology that the wall of the vein is thin compared to an artery. It's easily injured. So what happens here, if you want to cannulate a patient or catheterize a patient, to introduce cannula or catheter اللي بنسميه الفينس لاين، عايزين مدخل لأي vein علشان either we want to go inside either to administer drugs, to withdraw a specimen of blood, to introduce a catheter in a vein that will eventually go in the right side of the heart, the right atrium, to measure the central venous pressure there. This is the case of the external jugular vein. Please, if you want to catheterize the vein, to do anything, don't puncture the vein at lower levels, just before it pierces the fascia, because the walls are under tension. You will get swelling, you will get a hematoma. a big hematoma here, because the vein will get torn. When you puncture it, it will get torn because the wall's under tension. So cannulate the external jugular vein high up in the middle of the neck, for example, to be away from the area tense by the surrounding investing layer. You got that? This is very important, by the way. Tributaries of the vein, we said it's first the two veins that formed it already, the posterior division of the retromandibular and the posterior auricular. We have a transverse cervical, suprascapular, and posterior external jugular. All these veins are the major veins actually that are a part of a continuous network of superficial veins, which is varies between individuals, but these veins we mentioned are almost always present in all individuals. This is about the external jugular vein. The anterior jugular veins are two veins formed below the mentum, which is the union of the mandible in the middle. Two occasional veins. They don't have to be present on all individuals. They go down to drain into the external jugular, and they communicate in the suprasternal space we mentioned before by the splitting of the investing layer of the fascia. And this is the transverse arch of veins in the this is the content of the suprasternal space. Got that? By the way, the two anterior jugular system may not be present at all, replaced by a haphazard network of veins. We mentioned infections and cannulation. Now, the CVP, the central venous pressure, is when you want to go with a sensor inside the heart chamber to measure the pressure of blood inside this chamber. We usually go to the right side of the heart through the subclavian vein, but sometimes you need to go through the internal jugular, for example, or maybe with a very fine catheter through the external jugular. But when you introduce a catheter, it will go down to the right atrium, and the pressure you measure there is called the central venous pressure.